All right, hi everyone. Thank you all for joining us tonight for Bumps and Bundles. We are all just thrilled to have you here for a very important conversation. We wanted to really create a space tonight to talk about some of the disparities and inequities in maternal health for women of color. I'll start by introducing myself. My name is Cortina McCurry. I am the CEO of Kaya. Kaya is a women's health company that is really designed to be able to support women and families as they're navigating various life stages. And so the role that we play is to connect women with vetted and trusted medical practitioners to help them as they're moving through phases of life, such as the reproductive stages, fertility, pregnancy, postpartum, and even as far as menopause. So we're here tonight with a panel of just amazing and accomplished individuals. We will introduce all of ourselves in turn. Maybe what I can do is just turn it over to the panelists to introduce themselves. We've got Dr. Kudzai Katutu. Do you want to go first, Kudzai?
Yeah, sure. Happy to. Hi, everyone. I'm Kudzai. I'm a doctor, infectious diseases specialist, and a bit of a tech nerd, living and working in Melbourne, so Wurundjeri country, and very happy to be here tonight to share with the panelists and also with anyone attending tonight.
And we've got as well Dr. Stephanie Truss.
Hi everyone, so my name is Steph Truss. I'm a Gidja Wurundjeri woman from right at the top of Western Australia. I'm here because I'm a GP and in a previous life was an Aboriginal health worker and a nurse. So lots of experience in sort of dealing in maternal health, and also a mother myself, and I'm the daughter of an Aboriginal midwife. And so I hope to be able to share some of my learnings over my time with everyone tonight.
Great. We also have Winitha Bonnie.
Hi, so blessed and grateful to be here, and I just wanted to acknowledge the traditional owners of the land of which we're all standing on today, and to acknowledge our elders past, present and future, as well as any First Nations colleagues who may be listening on in this session. This land always was and will always be Aboriginal land because sovereignty never ceded at all. I am a thought leader in the advancement of women and people of colour into leadership and entrepreneurship. And, social justice really is at the heart of my work. And so through a lot of the research that I've done, I've often wandered, off track, and am aware of some of the issues that unfortunately mothers in our Black community and in our First Nations community are experiencing. And so my hope is through the session today that there would be many that would get the help and support that they need and that they deserve.
Great, and we also have Dr. Carmen Brown.
Thank you so much for having me. My name is Carmen Brown. I am a consultant obstetrician. I have been a consultant obstetrician for 16 years now. I've worked in New Zealand and also from the United States. My passion has always been obviously women's healthcare based on my specialty, but specifically, I found it very concerning about the inequities that we find in healthcare, especially for our Indigenous and Black mothers. Working in New Zealand with my Maori colleagues, seeing the inequities there, higher rates of preterm birth and poor outcomes. Same thing that I see with our Aboriginal and Torres Strait Island.
I think, Carmen, you've just frozen, but we'll keep going, and we'll come back to Carmen in just a moment. One of the things I wanted to say is, oh, go ahead, Carmen. We've got you now. You froze for a second, but
sorry. Not sure where it froze, but I was just saying that my passion is definitely taking care of these women and making sure that they have the tools that they need to be active participants in their healthcare and to reduce their risk of these poor outcomes.
Fantastic. And so one thing I wanted to say, what you'll see on the screen now is all of our panelists and their information and where you can reach them. As this conversation is really for you. We want to be resources, we want to be advocates, we want to be able to not just answer the questions that you might have tonight, but make ourselves available to answer any, be a support for you going forward. And so these slides will be sent out afterwards, so no need to take any notes or record this now, but they will be shared after the session is over. And we're also recording this, so it will be available for you to, if you can't stay for the entire time, you'll be able to listen to the recording afterwards. One thing that we'll be doing throughout the session, because your questions are really at the heart of this, you have two ways of being able to interact. Right now, if you get your phone and you just put the camera on the QR code here, it'll take you to Slido. So what Slido will do for you is it'll give you the ability to ask questions as we go through. We're going to share a bit of data up front and have a few slides, but ultimately leave time for conversation. So I'll give you all a moment to scan that QR code. I'll give everyone prompts as we go through. If you miss the QR code, it's fine. You've got the number for Slido up top. You can also upvote questions. So you'll see the questions that others have asked and are asking. And so if you have the same question, just click on the like button and that'll move that question to the top. So it'll help us as we are going through this session. Okay, great. Well, maybe we'll start by talking about why this conversation and really why now. Many of you are probably aware of the data that's out there when it comes to maternal health. Maternal health is getting worse, not better, in particular, as some of the panelists have already alluded to, for particular demographics. And so what we wanted to do tonight is recognizing that seeing that data and then going through this period and stage of life can often be a period where women and families feel much more vulnerable. We wanted to create a space to not create fear or anxiety, but to give you the opportunity to actually talk with doctors, to share those statistics, to share the numbers and the research, but to give you tools, pragmatic tools for what you can actually do about it. For me personally, this is an issue that's close to my heart. I wanted to be able to not just be an advocate, but also to use my platform, Kaya, to be able to support you and bring these doctors together, but also to share my own story, because I started a women's health company because I saw that there was a need to destigmatize some of the issues that currently exist and to improve the overall outcomes for women's health more broadly. That was the initial impetus for Kaya. But interestingly, during COVID and in 2020, I was reminded again of the importance of being able to start a conversation about the fact that some of these issues and disparities exist after giving birth to twins earlier this year. And so in March, just as COVID was hitting, I gave birth to two identical, beautiful girls. They were incredibly healthy. And after I gave birth to them, that's when things actually started to go wrong. And so the doctors quickly realized that I had what was called a placenta accreta. And I hemorrhaged. I lost more than 2 liters of blood. This is a good news story because I'm here. I'm here. And the doctors, I had an amazing team of practitioners that were able to stabilize me within an hour and a half. However, what was interesting about this story was not so much that I survived it, but that the placenta accreta was a surprise. It was missed. And it was missed for me, even after having a knowledge of women's health. It was something that I shared with my doctors, that they were aware of the fact that with my daughter, I had an emergency cesarean with her. And so that put me already at high risk for a placenta accreta. I'd had an earlier surgery that put me at high risk. I'm also a Black woman, and that puts me at a higher risk for it. And so one might expect that would have been something that even as someone who had twins at an older age, that might have been something that would have been a warning sign that they would have been checking for. Subsequently, after surviving this, my story didn't end there because, as I mentioned, this was something that was a surprise. And so as a result, they had to take action quickly. And it meant that they had to operate. And after I had gone into recovery, spent time at the hospital, and then gone home, it was only a month later that they realized, or that I realized, that they hadn't removed my stitches. And so I called my doctor, and I always go back to this moment where I called my doctor and I said, "Hi, I think that I still have stitches in. I can actually feel the knots going across my incision side." And he said, "Well, what do you mean?" And I said, I can physically feel stitches. And the response from my doctor wasn't curiosity or concern. It was, "That's not possible." And so I persisted, and I explained, well, I was explaining what they felt like and that there were these knots. And the response that I got was, "Well, I don't know what that is." And he hurried me off the phone. And I go back to this moment because even knowing that I could physically feel the stitches in the particular state that I was at the time, talking to a doctor, even knowing as much as I know about women's health and often our concerns being dismissed and not being listened to, there was this moment where I shrunk back. And I said, "Well, maybe I'll look again. Maybe I'll check." And he said, "Okay, well, you do that, and then get back to me." And I knew what was going on. And so I share that story because, and we're going to talk a lot about this tonight, there's often that moment where you know more. Maybe it's not something physical, but you can actually, physical in terms of stitches, but you know that something wrong. You're trying to express that to a doctor and you feel like you're not being heard. So we want to make sure we touch on that issue. The story didn't end there though, because I continued to have, I ended up going back in, and indeed the stitches were left in. So there was a period of having to go through a series of visits as they continued to try and remove the stitches. Not to be too graphic, but what happens is when you've left stitches in, they actually grow into your skin, which meant that it was actually quite hard to find them. I could continue to feel them, and they said, "No, they're all gone." I said, "Well, no, I think there might be more." And they would tell me, no, we've checked, it's fine. And then more would continue to emerge. So this went on over a series of, over several weeks. And finally, I said, "Listen, I can actually even feel there's something else. There's something else there." I had this large lump on my side, and my doctor said, "Oh, no. That's definitely not the stitches. That's actually something related to the initial surgery. That's just an internal stitch in your uterus. It's totally fine." Again, I had to fight. I had to fight and persist to be heard. Thankfully, what ended up happening is they realized that the best course of action, instead of continuing to go back, was to just have another surgery. So with my two young twins and my toddler, thankfully my partner, and it made, in a way, maybe this is the silver lining of COVID, he was home, and I had to go back in for a surgery. They had to open me up again to remove all the stitches. And lo and behold, when they opened me up again, they realized that I wasn't imagining that there was something else there, but there was a drain tube that had been left inside me as well. And so this whole experience for me was an experience which was, it was, while traumatic, it was a reminder of why shedding light on women's health is so, so important, why it's so important for women to have literacy and an awareness of their body, and to be given tools that they can use to advocate when they feel like they're not being heard. Because in my case, I knew about sepsis and the risk of sepsis. I knew that there was really something wrong, and I did persist. But I can imagine, knowing the vulnerability, there might have been others who said, "Well, if my doctor tells me that the stitches are fine, they're just fine," and that could have led to an outcome that isn't as positive as me sitting here today. And so we've gathered all of these wonderful practitioners here because I know that there are going to be many of you who have similar stories of trauma. You might be entering into pregnancy. You might be postpartum. You might be an ally that's here that's saying, "I just want to learn more." And so tonight I would say, we want this to be a space that's intimate. We want you to ask your questions, share any of those fears and anxieties. Our practitioners are here to help. And now I'm going to hand over to Carmen. we'll take you through some of the research, some of the data, and start to arm you with some of the tools that we are talking about tonight.
Thank you so much, and thanks for sharing your story. When I first heard Cortina's story, I was mortified as a clinician, not because it was so unheard of, but just because for a woman that, once again, as she said, knows so much about healthcare, women's health, and this is actually her business, that she was pushed aside and not heard. That was the same type of thing that worried me. And this is part of the reason why the stats are so bad. One of the things I just recently read is the issues that we're finding with health disparities is not about race, it's about racism. And there are structural things in our system that we are going to need to dismantle and literally tear down and start from the beginning in order to erase this inequity. So that's one of the things I want you to remember going forward, is that obviously we're not going to be able to change our heritage, where we come from, our culture. But what we're looking at is the actual systems in place. And what we're trying to attack is the systems and changing those from the ground up. One of the things I wanted to show you all is this is what Cortina was nice enough to put together with some stats that we found. And this is some global data showing us the risks of a maternal morbidity, which is a death event associated with pregnancy and childbirth. And this is looking at the United States and the UK, and we'll touch on Australia later, but we just wanted to show you how high these rates are. Like Cortina had mentioned before, the actual rates of maternal morbidity is going up in the United States. It's going down in most other industrialized nations, but it's going up in the United States. One of the resources we have at the end is a great article that says, if you want to tackle this head on, stop blaming mothers. I've heard a lot of clinicians say that the reason why these stats are so high is because women are more obese and they're waiting longer to have children, and they're eating poor, and they live in food deserts and these other types of things. And some of those are structural determinants of health. And yes, some of them do have a lot to do with these stats that we're looking at, but it's also the system. So once again, going back to the things that we're going to arm you with so that you can go into that system and hopefully have a much better outcome. As you see in the United States, white women have a 12 out of 100,000 births, 12 white women will have a pregnancy-related death. When you look at Asian women, that risk goes up higher. We did not put Hispanic women on this, but we wanted to just kind of keep it a little cleaner, just to show you specifically with Black women, as we're focusing on in this particular slide. But you'll see Black women have a 42 in 100,000 chance of having some type of pregnancy-related mortality event. In the UK, it's almost as bad. White women in the UK, 8, and then you'll see all the way over to the side, Black women at 40. And then globally, when you take all countries together, it's about 36. So you see globally, it's actually lower than in the UK and the United States, which are, of course, two giant industrialized mega powerhouses. So once again, this is not making sense. So in Australia, looking at our stats here, still no better. And I mentioned that I worked in New Zealand, same type of thing that you'll see. Indigenous women, and looking at North America and Canada too, you will see yet again higher risk for Alaska Natives, American Indian women, Native American women, and of course here in Australia with Indigenous Aboriginal and Torres Strait Islander women. So it's 4 times higher than white Australian women. And when you look at it per 100,000, the stats are staggering. So once again, a non-Indigenous white Australian woman will have about a 6.5 per 100,000 events. But if you are an Aboriginal or Torres Strait Islander woman, it's up to 26.5. Once again, these numbers don't lie. When we look at why these happen, if there is a good thing about this, is that most of these are preventable. In fact, 3 out of 5 of these are preventable. I do a course called Prompt, where we teach a multidisciplinary group on how to take care of obstetric emergencies. And the whole point of that is that so we can work as a team, in a really good fashion to make sure we jump in and save mom, save baby as fast as possible. And once again, we see the same stats that most of these deaths that we see are preventable, whether it be hemorrhage, whether it be hypertension. These things are things that you can sometimes see the writing on the wall before they actually happen. So we need to do better as practitioners as far as looking at the woman holistically and looking at the risk and how we can prevent them from happening before they do. Now, this is really important. This is about the fourth trimester. So, one of the biggest faults in the United States is that after a woman has her baby, her supports are completely lost in most cases, especially for our women who are lower socioeconomic status, women who are on Medicaid. Usually, if they have no insurance, their actual government insurance will expire 6 weeks after delivery. And I know that's hard for us to understand or wrap our minds around, especially if we're from like the UK, Canada, Australia, New Zealand. But for a lot of women, they're uninsured. And the fourth trimester, or the first 6 to 12 weeks after delivery, can be a very dangerous time. And in fact, we see a lot of deaths. In fact, in some statistics, most deaths will occur after delivery. So this is a really critical time to pay attention to our moms and still listen to their concerns. A lot of the things I've heard from other moms is that I had a headache. I'd already delivered. I went to the hospital and labor and delivery didn't want to see me anymore. I'd already had the baby. Or they went to the emergency department and no one bothered to ask, did you just have a baby, or how postpartum are you? So there's a lot of risks that are associated with postnatally that we just do not pick up on, and we don't do a really good job as practitioners sometimes. So we need to pay attention to that. So I wanted to make sure that you understand the fourth trimester, or after you've had your baby, is a very critical time as far as your health too. So as far as what happens in these complications, and I think Akadai is going to talk a little bit more about this, is that there's drivers of maternal complications. And as far as in Black and Aboriginal women, we do see several things that occur. Heart disease and stroke. We also see hemorrhaging, blood pressure and infections. And there's also pre-existing health conditions. And as far as the structural barriers, and we're going to talk a lot about this today, so this is definitely one of those conversations we want to have with you, the audience, is that there's so many different things that go into the problems that we see with accessing healthcare. So, especially with our Aboriginal and Torres Strait Islander women here, accessing healthcare and having access to having appropriate and culturally sensitive care. There's an authority problem, like Cortina had mentioned, that you feel like you're not allowed to talk to your doctor or ask those questions. And then, of course, there's a lack of cultural sensitivity. Sometimes you feel like they don't understand where you're coming from and your concerns. And then there's this implicit bias. I've heard so many stories about patients coming in, and the assumption is that they're uneducated, uninsured, and don't have any resources and are swept aside. And that's unfortunate because that shows you how everyone is treated if they look a certain way. And so that's very concerning. Being rushed through appointments, like Cortina mentioned, not getting a chance to ask questions and not feeling comfortable enough in the moment to have that time with your practitioner. And then unfortunately, we have a very fragmented system in some cases where you don't have the same midwife or doctor at each visit. So you feel like things are lost in the translation. And each time you might voice a concern and it's not mentioned the next time.
Pardon me. Let me just move that. Sorry, one moment there. Let's see what's just happened. All right, give me one moment. We'll bring those back up. I know you had also had some thoughts on some of those structural barriers, just as I.
Yeah, I think you're absolutely, Gar. I think the reason why we wanted to try and introduce those particular things at this moment is to really give everyone who's watching that assurance that you're not imagining it there are things that are happening when you're attending for healthcare that make it very difficult for you to get the answers that you need and the answers that you want. So Carmen had already spoken about the doctor authority and the power dynamic. And Carmen and I myself, I'm very aware of it. When someone comes into a clinical room, and Stephanie as well, you know that you are in the seat of power as the doctor in the room. You know that depending on how much information you either provide or don't provide, you can completely drive that conversation wherever you want it to go. This unfortunate thing is that sometimes when you're in a position of power and authority, you sometimes forget it. That sense of power becomes something that you just kind of become ingrained in. So, one of the things I think I try to do with a lot of my junior doctors is to remind them that you are in a position of power. And if you deny people the opportunity, or you shut down or don't create those spaces for meaningful exchange and for real question asking, the classic tale of the doctor who only asks closed ended questions. So, are you okay? Yes. Do you need anything else? No. Get out. As opposed to, is there anything that I have missed? Is there anything that you would like to discuss more? I'm just going to give you some moments because I know, it can be difficult to think. I'm going to give you a few minutes and write it down if you like. People who actually encourage you to write things down. So I think one of the ways that I've sort of considered unpacking or at least breaking down that power dynamic is don't be afraid to take a piece of paper and pen and write things down. So the question in the chat there around, well, I feel afraid with some of the jargon. Write things down, and it also gives your doctor a little bit of a nudge to think, oh gosh, this person is not just listening to me and just absorbing things. It's very difficult to absorb. This person is actually taking notes, and then you have something to take away with you, and when you come back, you might have that opportunity again. We also talked about cultural sensitivity and bias. We know the statistics for people going through medical school, you tend to be people who are of a certain class, so usually middle or higher, so people who don't have experience across the socioeconomic divide, and also people who've come from a monoculture of some kind. So that also lends itself to people not appreciating that not everybody has the vocabulary or not everybody has that sense of power to pursue what they want out of that clinical consultation. And from behind the veil of what we do in medicine as well, the appointments are really short. And that's a structural impediment that I think we as medical people need to actually challenge. So you should know also when you're attending for a GP or for other appointments, they actually have appointment slot time. So if you feel like you have a more complicated issue or you have more that you'd like to discuss, you can actually say, look, I would like to request a longer appointment. And obviously in places like Melbourne or Australia, you actually, it doesn't make any difference from a Medicare perspective if you're seeing someone who's bulk billing. So there are some ways where you can sort of start to ask those questions. Do I have a short appointment or do I have a longer appointment? The fragmentation is really challenging because even if you find someone safe that you're comfortable speaking with, they're not always there with you. And the parts of the healthcare system don't always talk to each other neatly. So I really encourage people, as much as you can, to try and maintain some sort of dossier or a paper pack of all of the things that relate to your health that you can then take with you. And yeah, there are doctors who will kind of go, oh, here comes the patient with the pack of materials. Ugh, I don't want to know about it. And that really is more about, I don't want you to come with thoughts in your head that might take me off the course of what I want to do to kind of get things done and get things done quickly. But it's important for you to contain that, have that information and be unafraid to have it with you, because it also allows you to keep track of things and also to remind people about things they may have forgotten. But sometimes I'll only see a patient or a client once or twice a year. I will often forget things that they mentioned at previous appointments. So I've gotten to the point now where I'm comfortable enough with myself and don't feel threatened enough that I'm happy when someone comes with a pack of, okay, last time I came to see you, we discussed these things. And since I've seen you, these are some of the things that have happened that might, be relevant to you. So I'm actually happy for people to do that. And I encourage people to keep your information and also to ask for your information. So if you've seen a GP, you're perfectly within your rights, or any practitioner, to say, look, can I have a copy of all of my blood test results and my information when you're in the room? Because sometimes it can be a lot more difficult to do that once you've left. And you do have the right to ask for your information as well, and to ask for that to be provided to you there are ways and processes for doing that. And just one other final thing to mention in terms of that lack of care cohesion and also how to bridge that power gap. In most hospital settings or most healthcare settings, there will be somebody who's a designated patient advocate or a liaison, and get to know some of those things, particularly when you're planning your pregnancy journey, and know how you would contact them before you actually need to contact them, because they are there and they're in a position in the hospital where they can at least be an ally or somebody who can help guide you through a difficult patch. And it's always so much easier to have those resources and have those thought processes in mind before it happens. And having your information with you, so your blood test results, appointments that you've attended, who you've seen, names of people that you've seen, is a very powerful way to show people that I care about my health and I know my stuff and I know my information, and I'm not going to rely on the hospital or the hospital systems to tell me what my health condition is, and I've got it all here. And it often really sets a good foundation for that relationship between you and your practitioner, if they're seeing that, you know, you're invested in what's happening and that you've moved out of that more passive role that we're often trained to be in, and you're actually there to be part of the conversation. I'll leave off there.
Thank you, Kudzai. And Stephanie, I know when it came to the cultural sensitivity, you'd wanted to share some of the things that are happening. There's a lot of positive actions you're mentioning are happening here in Australia, but also there's a context that people need to understand.
Yeah, absolutely. I was just thinking about what Kudzai said then, and that was really, really good, actually, just thinking about some of the practical things from a GP point of view as well. I tend to ask people, you know, give people the right to ask as many questions as they like, ask for doctors to explain jargon, to explain it properly, draw pictures or show me diagrams so I can understand it better. Could you print that off in my language, please, so that I can then understand that better? So it's really, I think it's really important. The other thing I encourage women to do is to actually probably have a support person with them, so that, you know, you're a bit like a deer in the headlights where you can't quite, or a kangaroo in the headlights, I usually say, where you can't think of what you might want to say in the moment you're with the doctor. Having a support person with you can be very helpful, because they can, especially if it's planned before they come in, that they're going to hold your questions and ask them for you if you're not given the opportunity to do that. So I think there's lots of really important pointers that that can help you in terms of your consult, and be able to give you some power back in being able to ask the questions you want to ask and feel like you've had a consultation that you're happy with. So I think really, you know, all the stuff we're talking about, of course, is really quite important for Aboriginal and Torres Strait Islander women as well. And you know, the cultural history. I'm from the Kimberley, like I said, and so you know, in my mother and older sister's lifetime, we can remember having hospitals that were, you know, we had black hospitals and white hospitals up here in the Kimberley. So you could, you know, when my older siblings were unwell, we were still discussing whether we're taking them to the black hospital or not. You can only go to the white hospital if you had papers to say you were a citizen in this country. So, you know, that history is actually not that long ago. My husband's from Cunnamulla, and when he was a teenager, we still had segregated movie theatres. And so when he was 16, he couldn't sit with his mates. So this history isn't that old. And so lots of people in my lifetime and around me now, and the patients we see and the people we see, still have this knowledge and understanding. So it's really quite raw for lots of people. And so trying to then find, you know, a commitment from especially government departments and organisations to have true, you know, models of cultural safety, especially around maternal care, has been something that's been slow to happen, but is slowly happening. And I think the reason that it's going to start, the reason that we need to, I think it was Carmen that said we need to sort of tear down these old models and actually start building new ones. It's going to come from us. That's where it's going to come from. It's going to come from us women standing up and going, this is what needs to happen. I think, you know, there's lots of, all that stuff we talked about around antenatal and postnatal care, especially the fourth trimester and looking after women. There's lots of we still have quite a Western model in Australia. And so when we're looking at, there's pockets of good programs and things around Australia, but in terms of proper change within government departments and large departments to be able to change the way they actually deliver maternal care, it's pretty lean on the ground. And so we're going to really, so there's been a lot of projects around looking at how we can do them. So I was involved in a project called the KMMS, which is the Kimberley Mums Mood Scale. And what we realised that when we're talking to Aboriginal women up here, especially when we're trying to do looking at maternal anxiety and depression and looking at even postnatal as well, we're using an old scale called the Edinburgh Depression Scale. And that's something that's still sort of widely accepted in Australia, that was developed obviously not in this country. So when you're talking about those questions from the EDS, and we had midwives asking those questions to Aboriginal and Torres Strait Islander women, but our Aboriginal women up here, they didn't quite understand. So in fact, they were, marking them as not having any issues around their social or emotional well-being. So we had to develop a mood scale that actually reflected how we talk and how we interact in terms of Aboriginal women up here. And then we had to, and I had another Aboriginal GP colleague who was part of that. And then we had to be able to validate that tool to be able to then look at how we might do that better. And then that research was done through the normal research, evidence-based research that we do in Australia, and then validated. So it's really interesting but we have to drive that, and then we have to drive that change. And so being able to actually change the way, the way the State Health Department, and trying to get them to integrate things like the Kimberley Mums Mood Scale into the way they look after maternal health is still, is still something that we still struggle with today. And the other thing I think we've got that in part of our resources, that stuff about birthing on country, that was done through the university up in Charles Darwin University up in Darwin, looking at this RISE framework, and I think we've got the framework somewhere there, yeah, in terms of looking at what we need to change and what Aboriginal women said we needed to change to be able to look at strengthening birthing on country and having stronger maternal and child health programs up here in our part of the world, because we saw those horrific statistics that Carmen showed us earlier, and if we keep doing what we've been doing all along, then we're not going to change anything. Nothing's going to change if we keep doing what we're doing. So we have to look at how we're going to redesign things so that we can make these statistics different and change. And we need to look at the strength that has been out there that we have had, especially in our communities, for thousands of years. And that, we have natural birthing women that are part of our communities, and those birthing women or Aboriginal midwives were the ones that delivered babies in our communities. But unfortunately, that right was taken away from them with all the other historical events that we've had in Australia in terms of taking away our rights. And so that has been, disintegrated in terms of being able to be a strong way that women can then birth on country. And at the moment, for example, in the Kimberleys, our rule for the state health, because absolutely we have high rates of chronic disease and hypertension and all those risks in terms of maternal health, but all our women have to come to a larger centre 4 weeks before at least 4 weeks before they're due to deliver, some 6 weeks before, and they have to leave their family and their children and their husbands behind and come to a large centre to deliver. So you can imagine trying to think about doing that. So those things we have to think about how we might change that. How do we redesign this health system? How do we invest in a workforce where you may, you do what Kadzo said, where you're talking about to young doctors, young nurses, and you're educating them about this, the way that we need to talk to people to be able to be culturally safe in the practices that we do. And we need to invest in positions we probably don't have yet. So I think Aboriginal health worker practitioners and people like that who need to then be able to train in maternal health and be able to work alongside health workers, midwives, nurses, doctors and obstetricians. They're the sort of things that we need to look at going forward. And this strengthening families is really something we've got very fragmented. You just have to look at our statistics around kids that have been taken away from families. I mean, now it's worse than it was in a stolen generation when both my parents were taken away, in terms of removing children from families. And how do we do that in a way that actually brings families back together and encourage stronger families? And really the community has to be embedded in this whole program. And we can, I mean, one program I'd love to have happen up here is, we have a tradition here, Mirrong people, when they welcome someone to their country, they pour water on your head and they welcome you to their country. So I would love for us, for women who are birthing in our hospital in our town, to be able to say, yep, I would like my child to be welcomed to this country. And we actually have a ceremony around that. We have a ceremony for welcoming people that are new to our country as a whole, but why don't we do that around here, and we actually strengthen that bond between that for our old people, that's really important to help that young person grow up strong in their place, whether they're Black or not. So I think all those things about embedding community, strengthen families, investing, so they call it the RISE framework, that's going to be really, really important. And of course, it's underpinned by all those rules and ceremonies and dreaming and laws we have on our country as well.
Wow, thank you so much for sharing that, Stephanie. As you're talking, and the thing that keeps coming to my mind is the importance of voice, of voice in all of this, that it's not top down, it's bottom up, it's listening to the individuals who are coming to the system and empowering them to have the births that they desire in a way that's safe. I think this is a really good moment for us to actually maybe start to talk a bit more and get some of the questions that the audience might have answered. I might hand over to you, Winifred. I think what I'll do is let's go and quickly glance and see if there's questions in the Slido, but I might actually just take the slides off so that we can have a bit more of a chat. And what I might do is then ask anyone in the audience, if you have those questions, we can go back to the Slido, but you can also just put it directly into the chat here in the webinar. So let's see what we do have a few things that are here. Maybe I'll just hand over to you, Winifred, and we can actually start to dive in.
Yeah, absolutely. Yeah, so much rich content there. And I know there will be many that will be replaying this session and listening to it again. And I think this session is a testimony to the fact that there is support out there, and that there are sisters in our community that have had many lived experiences who will be there for you if you are going through any difficult challenges in your pregnancy journey. We have a question here that says, I find that I'm often intimidated by the medical terminology and jargon that doctors use, and I don't speak up when concerned. Advice here would be great. Stephanie, do you have any advice for this question here in terms of, I think what I've uncovered in some of my work is that, women of color in general do struggle in speaking and in finding their voice because of systemic discrimination and racism that's existed and the trauma around that. So when you're in a situation where you need to ask those really important questions and you are feeling intimidated by some of the medical terminology and jargon that doctors use, and you are struggling to speak up because of that, what would you advise an individual to do?
I think some of it is a couple of things that I've mentioned before in terms of being able to have someone with you as a support. For Aboriginal people, and I'm not sure for other, Black women, that's something we would talk about here, but for lots of Aboriginal people, there's lots of, especially women, that often need someone with them. And that really comes from our background culture, which is more about, you couldn't really do anything on your own. You'd have someone with you to support and guide you. And often that would be a sister, a cousin, a mum, an auntie. So so having someone with you is always important if you can. And I've even been really quite creative about that, because I've said to women, if you can't have someone with you, but they're happy for you to ring them and put them on speaker, and then they can still be able to talk and ask questions. You know, we're in this day of technology now, FaceTime. So if you're comfortable with that, and you're happy for that to happen during the consult, then we could do that if you want to, or always with the patient permission, obviously. And I think the other thing really is a little bit of the second question, where that's whole thing about we do need to teach our workforce, and we do need to be teaching our nurses and our doctors with their students this whole thing about you know, the use of jargon and when you wouldn't be using it, when you might use it, but then explain it so people then can connect the word to what it actually means, and then have various means of being able to explain it. So I think a lot of it actually is to do with teaching our staff, our training students in that area. The other thing is I don't think medical schools really assess that properly. I don't think they put a high priority on the fact that you need to be able to assess someone's cultural competence, if you like, when they're a student, and that should be a priority on that, and they should actually be assessed and marked on that, because, you know, often as medical students, the other two doctors probably would have an opinion, but often we you know, we live for these exams that we've got to get through and pass. So why don't we make some of them important for people for these students to pass? And I think it often takes a little bit of practice, doesn't it, to be able to get to a point where you can say to the doctor, hang on, could you just stop for a minute, and I just want to ask some questions, or can you explain that to me again? What I often get in my practice is a lot of women won't say anything in the room, but what will happen is they'll come out of the room, and then often we're a practice of only one man and the rest women, so we're quite women heavy. So when they go out of the practice, they often that conversation might happen secondhand. So that might be in the community, or out in the waiting room, or with the Aboriginal health worker practitioners or the other nurses. And so often they will come back, follow that up, and we will call the patient back in and have a chat. Even if they've talked to another doctor and they felt like they weren't heard, we take that seriously. We ask for feedback, and we go and follow that up as well. So I think in terms of strategies, I think Katzai talk about some of those things in the actual consult, when you might want to go over again, but I think they're just my thoughts that come to mind at the moment.
Yeah, thanks so much for that. Kutsai, so if you are a medical student, and obviously the system is taking, you know, 10 years plus maybe another 50 to change, what is something that medical students can do right now to develop that cultural competency?
Yeah, absolutely. Yeah, so much you can do. And some of you might be familiar with teach back methodology. And that's something that we train a lot. So I worked a lot in refugee and migrant health. So teach back methodology is really about coaching you as the clinician. How do I ask questions in a way that's actually going to elicit the response that I want? So rather than asking someone a question like, have you been taking your medication? Yes. You would ask a question like, can you speak to me about the medications that you've been taking and what you're taking them for? In that question, you'll get a much more powerful response in terms of what someone's understanding is of the medications that they're taking and why they think that they're taking them. The flip side of that is that you really want to get in the habit of coaching yourself as a clinician to put yourself in the position of the patient or client and think through, how could I arm them with the sorts of skills that are going to make them more successful in their healthcare journey. So that includes you actually figuring out, if a patient had a serious event or an adverse event, where would they go? Who are the patient liaison officers? You know, who is the interpreter coordinator? Who was your cultural competency officer or person in the hospital, so that you are in first first name terms with them, and you know who they are and what their brief is to do, because often you can't solve everything by yourself. But once you know what the frameworks or the networks are within your hospital facility or your institute for supporting people, you're far better placed to actually guide people in the direction that they want. So there's no need to be a hero. Obviously, there are things that you can do in the consult room that will make you a better clinician and get better at asking questions and also answering questions purposefully and meaningfully. And if we kind of loop back to that original question around how to get around the jargon, I would really encourage ourselves as clinicians to give patients the sorts of questions that they could ask that will give them the answers that they need, and to get them to practice before they turn up. So if I'm thinking about my diagnosis, no one's going to be comfortable. Not many patients will be comfortable. Tell me more about my diagnosis. But you can ask a question like, what is the main problem that I'm here to see you for? Which gives you the answer about, firstly, what am I here for? Because often when we're sending medical appointments, we don't actually say in the appointment letter, what are you coming for? People just get letters in the mail or SMSs. They turn up and they're still thinking, my goodness, what exactly am I here for? Because often you're seeing a doctor about a specific problem as opposed to seeing them for the totality of issues or concerns that you may have. So as a medical student, start thinking about what are the tools and resources that you can impart to your patients, particularly if you're worried about them, and also get really good in terms of having the confidence to actually lodge a risk man or an incident if you see that something's happened that's not safe or that was really bad for a patient. And that's a real, a step outside of what we normally do as doctors and medical students, because we tend to assume or like to act like we're right all of the time, but get to know how to call it out when things are not going well, and get really good at supporting your patients and giving them the tools, the resources, and the language that they could take to their next appointment to make them more comfortable, to make them feel really empowered, so that you've shared something because you have an in-depth knowledge of how hospitals and healthcare work, and you've seen how things play out when somebody feels disempowered, and you're in a perfect position to arm them with the skills, the tools, and the knowledge to navigate through that and ask things in a way that still keeps them safe and in a respectful way, where they're not seen as a bad patient or a difficult patient, but they're also able to get what they need out of the consultation.
Amazing. And what I'm hearing in both, Kudzai and Stephanie, what you both shared is, many of us come from high context cultures. We come from collectivist cultures, and our cultures are built around community. So the encouragement there is support, just like what we're doing right now, and the importance of tapping into that support to get the help that you need. And also what I'm hearing is, as medical students or people that are practitioners, to have autonomy over their own learning of how they can support, women of color and Indigenous and Black women in their journey as well. We have a question here around, and I'll ask this one for you. The participant says, this is more for my sister than for me, but she had a fairly traumatic birth and I'm trying to encourage her to talk to someone. Can you recommend supports?
So the good thing is we do have quite a few supports, especially for women that have experienced or have anxiety, depression, or have had a really bad outcome. And it might not honestly be a bad outcome. So like Cortina had mentioned, she has 2 healthy, beautiful babies, which I've seen. However, it still was traumatic, and she's still processing that. And I think that sometimes when we see the outcome of a healthy baby, we just assume you're fine and you have to get over it, but that's not the case. We do have the perinatal anxiety and depression support here is PANDA, which is an excellent resource, and that can link you with counselors and therapists that can talk to you about outcomes that you might have had, work through anxiety and depression associated with your delivery or the pregnancy itself. There's also SANS for people that have suffered a loss during the pregnancy. Even if that was a first trimester loss, it is still a loss, and there are people that are available to help you process it. But as far as processing the traumatic birth that your sister had, first of all, I'm really sorry she had that experience, because I'm sure that's coloring the way she's thinking about her future family and it may change how she feels with her next pregnancy, or whether or not she even wants to have any more children. I think one of the most important things to do is, like Cortina had mentioned, is it would be good to write it down, not necessarily to share it with anybody, but to write down all the things that made you feel less than, made you feel scared, made you feel disempowered, so that you can actually process each one of those. And if you do have someone that you feel comfortable speaking with, if you do have that counselor, if you do plug in with Panda, it is a way for you to sit down and process each one of those pieces and actually be able to work through those and hopefully work towards healing. So I really, that's a huge takeaway for women, especially women of color, Black women, because we have had so many problems in the health systems as they are currently structured. I'm sure there are hundreds and thousands of cases where women have had really traumatic experiences. And I think that appreciating and understanding those and giving those women the space to talk about them and heal from them is so very critical. We do have those supports, and we have some resources that we'll have at the end that we can definitely talk about. But and we're here, so.
Amazing. So on that, Ranita, I apologize if I'm pronouncing your name incorrectly. Is there a way to inform women in the community of upcoming workshops where they can come together and discuss issues that they would like to have addressed? It would also potentially open the door to meet others for support. Anyone from our panel?
We had before COVID. Everything is in the context of before COVID now. In the United States, they started doing things like centering, which is where you would have basically group antenatal care services, which was a really great way for women to meet other women in their cohort with the same type of due dates, get a chance to go through the birth experience, having those kind of friend supports, but also having access to a regular midwife or doula that they could talk to and be with during each portion of the pregnancy. Now, I realize that we unfortunately don't have that at every hospital service, but several hospital services in the city do have something very similar, where they have bubs and babies or mom meets or things of that nature. So I would highly recommend, when you do book in with your birthing center or hospital, do ask about that. And it's not just childbirth education you're asking about. You want to ask whether or not they have maternity groups, because once again, I think a lot of public hospitals do have those available.
One of the things we
And
are going to be offering Kaya as well. If you go to www.askkaya.com, one of the things we're launching in the new year is a concept called Kaya Circles. And the idea of a Kaya Circle is that it's exactly that you'd be able to come together with a group around specific issues or concerns. So you can actually go onto Kaya Circles. You can leave your email address and you can actually let us know what it is that you are particularly interested in. So it's not, in that case, it's not just for pregnancy and postpartum. We'll also be offering it for women who want to have supports around endometriosis, around PCOS, infertility as well.
I just wanted to add, I guess, because we're a long way from a large city, and so lots of smaller remote country areas, if you've got a GP that you trust, I do quite a bit of advocacy, as you can imagine, and no doubt there's lots of GPs around the country who do that. So if you have, if your sister has someone that helped share her care, or a GP she trusts, or someone that's recommended to her, potentially she can go in to talk to someone like that, who can also refer you through to psychological supports and things if that's needed, as well as being able to talk you through, because often there's other health issues that you need to potentially be cared for in terms of a traumatic birth. So just wanted to add that, really.
Yeah, great. Thanks, Stephanie. Kudzai just has a question here. You talked a little bit about structural and systemic change, and we all know that's a very large beast. But Jess here asks, her question is, where do you guys see the leverage points for change in maternity care that we can do better? I guess I'm asking more on a cultural institutional level rather than an individual healthcare level. As a midwife, how can I be best part of change on that scale?
Yeah. Look, Jess, I think the first thing to say is you should never underestimate what you can do at the bedside on an individual basis. And you're clearly somebody who, like me, has that sense of what does this look like at scale? And it can sometimes be frustrating when you're just kind of dealing on a patient by patient basis. But please never underestimate the vast difference you can make just by being there for a woman, seeing her through her pregnancy journey and connecting and making that personal commitment to making yourself better and more culturally aware. And there are lots of organizations that do a lot of this sort of work. So Center for Ethnicity and Health, the Multicultural Center for Health, Multicultural Women's Center for Health. There are so many organizations out there whose express purpose is to elevate and to advocate for the improvement of women's health at scale. So I think the first thing for you would be to find out where those organizations sit, where they live, because often the biggest challenge they have is actually finding people who work at the clinical interface who are prepared to contribute some time or effort or energy in terms of understanding what they do or even helping out. So, number one would be get familiar with what exists at an institutional level. So, within your own organization, what groups are there? Who are the key people who might be in a position to make decisions? When you're having your ward audit or your unit audit, start being the one who asks those questions around, look, we've spoken a lot about COVID, but what are we doing specifically for people or women who don't have English as their first language or women of different cultures? Be the one that starts to ask the questions, because one of the reasons that things don't get changed or they don't get fixed at that institutional level is we all just get so busy going along doing whatever we're doing that we forget to be the one who asks the question. And sometimes it's not a case that things are not happening because nobody cares. It's just because nobody's ever thought to ask the question or to have a meaningful suggestion of what could be different. Whether that is even you being the one who says, look, every week we've had sort of coaching or training, or we have our unit learning or session, would it be really great if we could have some of the interpreters come and talk to us about how they would like us to work with them? So be the one who asks for the opportunities and invites those opportunities into your organization from within your unit, and then start looking outside of your organizations to organizations that are tasked with doing this precise thing. Because I think there's a nice link between one of the other questions there around what can public health professionals do. Because the challenge with public health is that public health professionals can feel too distant from the patient. They're thinking, well, if I'm just kind of out here at a policy level, what could I possibly contribute? Wherever it is that you happen to find yourself in that sort of sphere of public health professionals, number one, get to know the data. And if you're in a sort of a publishing space, you can be, maybe that's your contribution, is that you actually publish or you encourage or you steer a conversation about, what your research group or your public health group should do next towards matters or issues that relate to women and women's health. So wherever you are placed, there's always something you can be to be the one who steers the conversation. But in order to be powerful, you need to have thought it through, because you don't want to be the person who, there's a meeting and you're like, oh, what about women? It doesn't penetrate. You actually need to be intelligent and a little bit strategic about when you introduce that conversation and to present the facts, and to also understand if you're going to be trying to advocate for some sort of change in the space that you're working, that people respond in different ways. So some people, know your people, some people will be motivated by, if you gave them the data, and similar to what Carmen provided around, the rates of black, Asian morbidity, Hispanic. If you presented that data, for some people they'd say, oh wow, that's shocking, yeah, we should do something. Whereas for other people, the language of advocacy that they hear is the one about the story. So you might share the story of, look, I heard at this hospital this happened to a woman. So get to understand your people and the space that you're working in. And what is the currency? What is your currency of power? Is it publication? Is it meetings and presentations? Is it, you have a relationship with a funding body? What is the currency that you deal in terms of power and privilege and access to change things? And what is the language that those people in that space speak. And if you can get to know that, you will find yourself increasingly in positions where you can actually steer things in the direction that you feel is right, and will provide some sort of, restorative justice in what has been, a long period of time where women haven't always had the opportunity to do that. I hope that kind of gives you some tips.
Yeah, the way you put that, Kuzai, that you broke down the like knowing your audience, because it's true. There's some people who have data fatigue, right? A lot of the data isn't new. We see these news stories. The data's out there. It's happening. You've got individuals who you've got this report and that report. I mean, they've been documenting this data. What's so shocking about it is you go back to like the 1980s, and a lot of the numbers in some cases have improved for some countries. But on balance, the ratios aren't that different, which is part of the thing. So sometimes you get the data fatigue. But I love what you're saying about knowing your audience, because often it's the stories that might cut through, maybe. It could go the other way, where some people say, well, oh, I've heard so many of these stories that they're no longer, it doesn't penetrate in the same way. I think one thing I find really interesting, at having gone through this experience myself, is, what Carmen started to touch on at the very beginning, that it doesn't matter it's not education, it's not income, it's not status. Those things don't protect you when it comes to maternal health at all. You get the stories. We hear, everyone now has heard the story of Serena Williams, for instance, tennis player, calling for help because she knew her own body. She knew that she had a history of being able to getting these blood clots. And she said something's wrong, and no one would listen to her. And this is someone who is recognized globally. And she had to yell, scream, and fight to get anyone to pay attention to her. But one thing that's interesting about Serena is because she's now sharing that story, and there's this conversation that's starting. I think it's starting to cut through, but data's not enough, education's not enough, finance isn't enough. So really knowing the organization that you work in and being able to speak the language that works there it resonates with me as well, because you sometimes have to maneuver when it comes to these things. But the last thing I would say is that I also think there's something about this space where the role of allies becomes incredibly, incredibly important, because it can be, we were talking about this, Winifred has a wonderful organization and has recently done a conference called Colorful, which is fantastic. If you didn't catch it this year, I would say follow Winifred on Instagram and catch it next year. But it was really starting to explore the experiences of women of color who are in leadership positions, starting companies, and bringing these women out of the shadows, effectively, who are doing these great things, but often aren't getting those supports. And one thing I thought I took away from that conference that I think is really important here is that there can often be fatigue to have to constantly defend yourself and explain that your experience is relevant. To say, this is happening to me, this is happening to my people, and have to be the one to explain it and fight for change. But to have allies come in who say, you know what, this might not have happened to me. I may not be a woman of color, but there's something that's not right here and I want to do something about it. And to have someone else speak up can often just take the load off. And interestingly, it can often help in terms of getting that message out and making more people aware. So it's as simple as sharing it with your friends and your family members, talking about it over lunch and say, hey, I just read this thing. What do you think about it?
You're speaking my language, Cortina. I always say to people that, allyship is not an option, it's an obligation and an expectation. And it's not about saving anyone, it's about serving. And, if we are not constantly surrounding ourselves by the voices of those that need our support, then how do we know? How are we informed around the actions that we need to take? Because it is their voice that needs to lead the actions that we then take as allies. And so on that note, Stephanie, a lot of the conversation I'm hearing is really around, support both for, the practitioner, but also for, for the patient. If we were to talk about public health professionals and how they can implement or what they can implement to provide support for improvements in maternal services in Australia, what are some of the things public health professionals can do to create systemic change, or to at least be on that path as an ally to provide systemic change in particular for Black and Indigenous women?
It's interesting because I'm just listening to the conversation, because definitely in terms of strategies, there's 1,000,001 research that's been done in this area, and 1,000,001 sort of strategies that's been talked about, including some of the ones that we talked about Rise earlier. And I think that can, and sometimes when you're doing this for a long time, and I understand that fatigue, because I definitely at times, when you have the responsibility of being able to advocate on the ground, then that can also be tiring. And so I wrestle with this. I struggle with this stuff around how do I then talk to public health professionals about what they might do. And I think some of what Kata said is actually really important in terms of knowing who your allies are, knowing who's around you that you might have to leverage off, and then knowing the language you have to speak to be able to then implement strategies. Because when I've done that, I've been doing this stuff for 30 years, as you can imagine, most of you probably exactly the same, that that's actually crucial. I was just thinking about the Kimberley Mums mood scale, because that came from women. So women on the ground are saying to us, to the midwives and to the Aboriginal health workers, what these questions you keep asking us, because they don't really make sense to us, and what are you trying to say, and what information are you trying to get out of us in terms of talking to the Aboriginal health worker practitioners. So, and that is where this whole conversation then came about. How do we, okay, this is a good question and this is really important. And then they started telling their story. So, we're talking earlier about, is it stats that you present, or is it a story you present, depending on your who you're trying to influence. So that then meant a group of us had to then, and again, it was allies, and it was Aboriginal and non-Aboriginal allies coming together to say, this is an important issue for these women, then looked at it more broadly, and then got, in fact, public health and others involved in terms of a research project to look at this properly, because then you have to speak the language of research and evidence-based research in medicine to be able to get strategies across the line. So that's just, I guess, my experience of trying to help things improve, and that was a ground up. But there's definitely other ways to do this. I mean, there's lots of things where the research has been done. If you look at the RISE stuff, for example, and there's good strategies out there. So instead of reading that, understanding the evidence behind that, and then advocating and then pulling allies in, as Kadzo talked about earlier, I think that's going to be really important when you're trying to affect change. Trying to talk to politicians and trying to talk, I find when you're in from where I sit, it's really those allies at a local level, at a regional level, that then the story gets told, and the research and the stats then talk for themselves, that we can then influence. And I think for public health professionals, it's really being able to try and tap into that and be able to, because we have public health professionals right around Australia, so being able to then tap into that's going to be important from their point of view. So I hope that sort of answered their question.
You made me think of one thing, Stephanie, actually, and it goes back to something, Carmen, you've talked a lot about before. And one thing we say at Kaya often is it's really about that getting women the body literacy and the education that then leads to the advocacy. And if women can start to advocate for themselves, or at least then bring someone in and help them to advocate, that's what's going to get us to better outcomes. But Carmen, I mean, would you be able to even touch on what are some of those factors that women should be aware of, right? We almost have to educate ourselves just in case the doctors are missing these things.
Right. I think it goes back to, once again, the health literacy and also feeling comfortable with speaking up in the room. So, for example, we talked about the structure of the system. I think one of the problems in the system, I personally think, especially in my specialty, looking at the gynecology and obstetrics side, is that a lot of this information you're giving to the patient, and the system, it's not built in a way that this information is given to the patient and allowing them to digest it in an appropriate way and then making an informed choice. The system is set up so you come in, you see the patient, you do an examination, you tell them the diagnosis, you tell them what you're going to do, you send them home and say, we're going to see you and do this, that to the other, to you or your surgery or whatever next time. And to me, that doesn't give the person a chance to process, digest, and ask the appropriate questions. So the way I feel is that the system is once again failed in that very essential space right there from the beginning. And that I really feel when you see a patient for a consultation, you are getting that information, that background, that cultural background, understanding where the patient is coming from, what their concerns are, what has happened in the past, what has been tried in the past, their concerns. You're starting to open that conversation and gain that trust. The other thing I think that needs to happen in that space is that you should give patients information in a lot of different ways because we're not all the same type of learner. Some of us are visual learners. Some of us are auditory learners. And so some people, if you speak to them and tell them what it is, and do not use medical jargon, do not do that. But if you're speaking to them, sometimes that's the way they'll absorb the information better. But for other people, you draw them pictures and diagrams and print things off, and that's a better way of doing it. And so because I don't know the best way of getting that information over to the patient, I believe that very first consultation is so that you can give them all the information that they need and then send them away with it. That visit should be at the end, you should say, I'd like you to take this home. I'd like you to go home and digest it. I want you to show this to your friends and your family, your support people. I'd like you to discuss it. I'd like you to look it up, and then you come back and then we're going to talk about it. And that's the way in the perfect world it should be, to give them that chance to process it rather than sit there, stare at them, and have them try to make a decision on the fly. So I think, and I know I'm a little bit off the question, but I think one of the things that was really bothering me earlier when we were talking and someone had brought up the question about the jargon, as clinicians, we shouldn't be using that because that's a way to immediately alienate a person. And that is not the way that most patients will come into that space, understanding what you're saying, that it immediately will put those walls up. So I believe that one of the first things we should do is giving the patient information, allowing them to digest, allowing them to use their allies and their supports to figure out if this is going to be the right thing for them, and then bring it back as a conversation that you can have fully with them being more empowered.
Amazing. We have a question here from Melissa who says, this is very valuable information and I know a lot of people who need to hear this. Would we be able to disseminate the recording to people who had registered? Yes, I believe. Or hadn't registered. Okay.
We can, what I can do is I can host it on Kai. I can put it up on our website so that it's freely available to everyone. And then when we send it out to those who have registered, please feel free to share it broadly with your networks.
Yeah, amazing. I just wanted to ask Cortina, one of the things that I see happen sometimes is that sometimes there can be a tendency to gaslight yourself in a moment. So you might have been, engaged in a range of situations and scenarios where you have then been gaslighted. And I think sometimes over time we start gaslighting ourselves. So when women are going through that journey of pregnancy, what are some of the scenarios that might happen to them that would point to implicit bias or straight out racism and discrimination?
Wow. That is such a good question. And I don't remember who said it, but somebody talked about that pack of materials going in with your kind of dossier and your information. So what I would say, after the experience that I've gone through, what I would say to every single woman when you go in to your doctor, to go in with eyes wide open and recognize that whether unconsciously or not, there may be a tendency for the doctor to not hear you, to not hear what you're saying, and to potentially kind of move your concerns to the side. And when I say that, I'm not saying that in a disparaging way, but I've had male doctors, OBGYNs explain it this way. These are the ones who have said they had a moment of awareness that There was a stat that came out that said within the first 18 seconds of a woman expressing her concerns, she was interrupted. And this was a male doctor who, hearing that, said he had to reflect. And he realized he wasn't interrupting her because he wasn't concerned about what she had to say. He actually believed that he had the answer because he immediately went into problem solving mode and he wanted to solve it for her. And so he stopped listening. And so I'm setting that up to answer your question by saying the best thing that a woman can do is to walk into the setting, recognizing eyes wide open that these implicit biases might exist, that there might be issues or concerns that may not be heard. And so what I would say is write it down. Because what I found, even with my twins going through, having a practitioner that was considered one of the best in Australia. I mean, he has one of the most respected reputations that you can imagine. And in fact, he had said, tell me your questions. Well, what I found is I would go into those meetings and I would forget. Because you go in and it can be quite intimidating. There's something about the patriarchy and the way that it's set up. We're set up to look up to our doctors, to have our doctors tell us what's going on with us. You don't want to interrupt. You don't always want to question. You're afraid of offending. And this could just be me personally, but I've spoken to others where there's a bit of a culture of don't bruise their egos, right? They're the doctor, they know better. So what I would do is I would write everything down. I also took my partner with me, but I would use my phone often, just right there in the notes section. I would write down every single thing that I wanted to cover with the doctor on a checklist. And when I went in, even when I started to have that moment of feeling as if I was talking too long, or maybe I was taking up his time, it's almost this concern of taking up space. I'd say, no, get through your checklist. And I would check them off one by one. So I think when I to answer your question, it's going to avoid being, having that feeling of gaslighting prior to even going into that space, prior to starting on that journey. Write down the things that you need to know. There's a few resources that we have as well that we're going to share with you, a few checklists. You can print those checklists out and you can take them in with you and you can say, here are some things I want to talk to you about before we kick off this journey. I am a woman of color and I've heard about the following things. How will you be checking preeclampsia, monitoring for gestational diabetes? I've had a history of cesarean sections. Does that put me at risk for placenta previa? How can you check that? Have you checked it? What are you going to do? Asking questions, write it down. Don't even make eye contact, just look down and read your list. That's what I find works.
Yeah, and I find that really powerful as well, is to name it, to name that I am a Black woman, I am a First Nations woman, I am a woman of color, and to make that and I feel like when that language is used, I think the attention in this space changes a little bit. I think people tend to have their ears more tuned in. Does anyone else have any other closing remarks that they'd like to share with the audience?
I wanted to go back. There was just one thing that one of the, I think midwives had mentioned about what could we do in our space as medical professionals. And I shared with Cortina, one of the things I thought was very shocking is that when I came to Australia, there was no cultural education around how to appropriately and safely take care of our First Nations people. And I thought that was very odd because in New Zealand, it was automatic and required part of your employment, whether you were working in environmental services or if you were a physician. So I found that was very helpful to learn how to appropriately and safely and culturally competently take care of my patients. And I thought that was unfortunate that I did not have that same experience coming to Australia as a foreign doctor, really unsure about the culture here. And I had to seek that out on my own. So to answer, going back to that student's question is that, you can seek that out on your own. You can take those cultural competency courses and classes to learn how to be the best possible practitioner for those people. And you actually, it could end up being the go-to person in your center, especially if you really make it known that you care about this and you want to make sure that these people feel heard and safe and supported. So definitely seek that out and don't wait for it to come to you. If you truly care about this space, please do seek those opportunities out.
And I'm just putting up on the screen now a set of resources that you'll find in the deck. This is there's a checklist of 10 things every Black woman should do to have a safe birth, but that would apply broadly to everyone, regardless of color. There's some really great things in there about how to prepare yourself in advance. It goes back to having that checklist. there's actually also at the end a fantastic checklist for prenatal and postnatal care. So this is really, these are tools that you can print out and you can take in with you. There's a few other fantastic resources that will also just give you more information around the current stats and the current state of care.
Amazing. And if women are looking for more support, where would you advise them to go? What's the best place for them to go get some immediate support?
So you'll definitely see a lot of those supports here, but I also want to go back to our panelists. As the first stat, I think what you'll see in the materials that we sent to you, you're going to see a lot of great resources. But let me just, sorry, I've lost the deck. But you'll see those sent out to you. You'll see a lot of great resources that will give you tips and suggestions for local supports that are available. But please don't hesitate to reach out to any of us with your questions and concerns, and we'll put you in the right direction. And yeah, I think I'll just end on something where we started, which is to really say that the first step towards better maternal outcomes, even recognizing the system that we're in, really starts with awareness and education. And from there, that's how you get to the self-advocacy, and that's how you start to get to better outcomes.
Amazing. Well, thank you so much to Cortina for her and her team in putting this session together. Amazing. There's a lot of hard work that went into it. Thank you, Kudzai and Carmen and Stephanie, for sharing your wisdom and your truth and your stories with everyone today. And for everyone that's listening in on this recording, or maybe with us currently live, know that you are not alone. So when you walk into spaces, even if you are physically not alone, the thing that I always communicate to people is that you actually walk in with your ancestors as well. They have walked that journey, and those ancestors that have been mothers, they are with you in that space, holding you and birthing their wisdom to you as well. And I really encourage people, I think Stephanie touched on this a little bit, I really encourage participants and listeners to dive into their cultural practices and their rituals. A lot of us have beliefs and practices around the birthing journey, and just in terms of our culture in general. And that is an important part of our identity, and that helps build our power. I think Kudzai mentioned that in some of her conversation, her share about the importance of standing with power, and also what was talked about in the session was being really intentional and being very strategic. And I think we could say that that's both relevant for both the practitioner and also for the patient as well, that we approach a situation with deep intention and are very strategic as well. But to know that you are not alone, and we have these incredible women that are there for you, and there are other support services that Carmen also mentioned and shared, and that will be shared with you on the slides. Bettina, do you want to officially close?
I do, because you have touched on my favorite quote that I have shared with some of you before, which is from Maya Angelou, which is that I come as one, but I stand as 10,000. And so I want to thank Winitha, Kudzai, Carmen, and Stephanie, because as I have gone through my own journey of healing from the experience that I had, these wonderful women showed up to support me, and they're showing up here again to support all of you. And I think that knowing that you have that support and finding that that circle for each of you is so, so important. So thank you all for joining. Thank you for your wonderful questions. Thank you for entering into the space with us. And I hope that you share this webinar widely with people, and that it benefits both you and others. Thank you all so much for your time.
Thank you so much for having us.
Thank you.
Take care.